Okay, everybody, Dr. Rafich here from Vet Triage. We are continuing through this issue of Veterinary Surgery, November 2024, and we're going to be talking about the stabilization of 82 sacroiliac luxations in 67 cats using 2 sacroiliac screws. Cases are from 2014 to 2023. This comes out of France. The objective is to describe sacroiliac luxation stabilization in cats using 2 screws and to report outcomes. So we're talking about this joint right here, the sacroiliac joint, is where the ilium attaches to the sacrum. So that's the SI joint. Here it is right there. And here's 2 screws in this radiograph postoperatively. It's a retrospective study, 67 cats. 2 screws per side affected. One was placed in lag fashion, one positional. So a screw placed in positional fashion means that literally just you drill the hole, put the screw in. Lag fashion is where you drill the hole, but then you over drill the part where the head of the screw is going to engage. And the thought there is that when you then place a screw, that over drilling of the head will help sink that screw in even deeper. The percent of sacral purchase for each screw, the percent of reduction, and the pelvic canal width ratio were measured and calculated. Results: they used 2.0 millimeter screws and 2.4 millimeter screws. The mean percentage of sacral purchase for lag and positional was 46% and 31% respectively. The median percentage of reduction was 89%. The mean pelvic canal width ratio 1.23, median follow-up 87 days, full function 81%, complications 4.7%, include loosening and breakage. Pelvic canal diameter was maintained in all cases. The clinical significance: feline sacroiliac luxation can be stabilized using 2 sacroiliac screws. All right, so the introduction. This is the most common pelvic bone injury, up to 59% of cases. With unilateral cases, the luxation is accompanied by 1 or more pelvic injuries, pubis, ischium, or contralateral ilium. Bilateral luxations without concurrent pelvic injuries occur 18 to 46%. Conservative management can be considered such for those patients that are ambulatory with less than 50% displacement of the iliac wing, minimal pain or instability, no fractures involving weight-bearing axis, no neurologic deficits, and no substantial pelvic canal narrowing. There are several methods for surgery: single lag fashion screw, single transsacroiliac pin, single transsacral screw and nut, transiliac techniques, tension band technique, ventral screw placement, transsacroiliac toggle suture placement, and single sacroiliac cannulated compression screw. You're going to want to know those if you're a surgery intern or resident. A single lag fashion screw is most often used in cats. A sacral purchase of at least 60% with the largest possible screw is recommended. This limits postoperative complications, which include screw loosening, narrowing of the pelvic canal diameter. Anatomic landmarks on the iliac wing and sacral body and screw angulation have been determined to define a safe sacral corridor for screw placement in cats. This safe corridor is limited often with less than 0.5 centimeters squared area reported in cats, and the optimal screw purchase can be challenging to obtain. Accuracy in screw placement and sacral purchase are better obtained using fluoroscopic guidance. In 1984, a study determined that a construct using 2 screws with a smaller diameter was stronger and stiffer than using one single large screw for dogs in an ex vivo model. More recently, in a static low displacement ex vivo canine model, it was shown, so ex vivo means outside the patient. It was also shown that a construct using 2 shorter screws of 3.5 millimeters, stronger, stiffer than using a longer screw with a 3.5 millimeter diameter. No mechanical advantage was observed between screws placed in positional versus lag fashion. All right, surgical procedure. These cats were anesthetized with diazepam, morphine, ketamine, aflatoxin, isoflurane. During surgery, they have a CRI of morphine and then meloxicam, cefazolin, The reduction was considered optimal when the caudal dorsal iliac spine was located between the first intermediate sacral crest and the first lateral sacral crest. And that's I mean, it's very difficult to see, but it's that region right over here. So it's very, very specific, very narrow area that you're aiming for with the screw. In this picture here, this little area there, that is the C-shaped hyaline auricular cartilage of the sacral wing. And then postoperatively, morphine and meloxicam. In this image down here, right here, the caudal dorsal part of the sacroiliac joint is marked by a red asterisk. That's a tiny thing right there, red asterisk. The caudal dorsal iliac spine is the arrow right there. And this is located between the first intermediate sacral crest, which is a blue arrowhead, and the first lateral sacral crest, which is a purple arrowhead. So just very narrow area. 6 to 8 weeks postoperative recovery when the cats went home. Measurements obtained with radiographs include the percentage of reduction of the sacroiliac joint. So this is the percentage of contact between joint surfaces. The percentage of sacral purchase of each screw, which is the percentage of the length of screw anchored in the sacral body. Report on the width of the sacral body. The cumulative percent of sacral purchase of each screw is the addition of all those percentages for each screw. And then pelvic canal width ratio, which is the ratio between the pelvic width at the acetabulum's cranial aspect and the caudal sacrum's width. You want to have a pelvic canal width ratio of 1.1 or greater, and that's considered optimal. And so this is the measurements right here. They were measuring for the pelvic canal width. Postoperative CT scan was performed in some of the cases. Sacral screws were classified as following. Grade 1 was referring to screws that were fully contained in the sacral body or exiting the ventral cortex by less than 2 millimeters, so complete anchor through the transcortex. Then there is grade 2A, which screws are slightly placed dorsally with vertebral canal penetration less than 50% of screw diameter. And then 2B, which is screws exiting more than 2 millimeters from the ventral cortex. Grade 3 are screws penetrating the vertebral canal by more than 50% of the screw diameter. And then screw placement was considered excellent when it was grade 1. And so here is an image there. A shows a lag screw and B is a positional screw on CT scan. So there you have it. Very, very tiny structures, very narrow windows to be successful. Results. Most cats were domestic short hairs. It was 50-50 male-female, median age 35 months, body weight 4 kilograms median. All the cats were non-ambulatory. Most of them had proprioception. Most of them had voluntary micturition. Right and left side were equal. Concurrent injuries were also seen, include pubic fractures, ischial fractures, iliac fractures, and more. Some had femoral fractures, mandibular symphyseal disjunctions, hip luxations. Some had concurrent procedures performed as well. For immediate postoperative radiographic evaluation, again, they use a lot of abbreviations, so I have to go back to the definitions. Okay. So the mean percentage of sacral purchase for each screw for lag was between 30 and 47%, and for positional screws, 30 to 32%. The mean cumulative percentage of sacral purchase of each screw ranged from 74 to 78%. The median immediate postoperative percentage of reduction of the sacroiliac joint, 84 to 89%. The mean pelvic canal width ratio obtained immediately after surgery was 1.19 to 1.25. Remember, they said that 1.1 or greater was optimal. And then for CT scan afterwards, 98.5% placement within the sacral body was considered excellent, grade 1. The ventral cortical of the sacral body was penetrated for 45 screws, so 20 lag, 25 positional, which meant 68%. The mean CAT scan percentage of sacral purchase was 50% for lag and 31% for positional. The mean cumulative percentage of sacral purchase, 81%. The minimum cumulative percentage of sacral purchase, 38%. associating 21% for lag and 17% for positional. Excellent agreement between X-rays and CT was obtained. The median dorsoventral screw angle was 22 degrees for lag, 23 degrees for positional. And then finally, for follow-up outcome and statistics, follow-up was median of 87 days. The mean pelvic canal width ratio obtained during follow-up, 1.21 for all cats, 1.22 for cats with CT scan post-op, 1.2 for those with only radiographs, and then complications were breakage and loosening. Other complications include minor, like persistent tail paresis, contralateral sciatic nerve paresis, which resolved, obstipation, and urinary incontinence, and then one major complication of obstipation. I'm not sure I agree with those being minor complications. That seems kind of weird. And then they have obstipation as both major and minor complication. That's weird. The functional outcome was considered excellent, 81%, acceptable in 19% of cats. Function considered excellent, 80% of cats, acceptable in 20%. So basically 80-20. Pelvic canal diameter was maintained in all the cats. The reduction of the sacroiliac joint did not impact the sacral purchase of lag or positional screws, nor the functional outcome. Bilateral surgery did not impact the quality of reduction, the sacral purchase of lag and positional screws, or the pelvic canal ratio in comparison with unilateral. Cats with concurrent pelvic fractures involving the weight-bearing axis did have a lower pelvic canal ratio in comparison with other cats. There was no impact of concurrent pelvic fracture on the quality of reduction on the sacral purchase of lag and positional screws. Discussion. So these cats were stabilized using 2 sacroiliac screws placed in blind fashion technique, one placed in lag, one positional, excellent outcome, 81%. It had already been observed that, except in giant breed dogs, space in the sacral body is insufficient for a second deeply set screw. Screw placement was considered excellent for 98% of these cats. It was better than previously reported, with minimally invasive techniques ranging from 84 to 92%. In other studies, screw placement was considered excellent if a sacral purchase of at least 60% preserving the vertebral canal was obtained. And the reference point in this study was for the lag screw, determined according to anatomical landmarks on the sacrum. Also, the ventral orientation of the screws in this study directs them away from the vertebral canal, and they also use small screw diameters in this study, so those are factors that may attribute it to their success here. So the percentage of sacral purchase of at least 60% is recommended when you use a single lag screw, which decreases the rate of loosening. Another study reported that 23% applied to 2 cortical screws has even better stiffness of stabilization than 60% applied with a single cortical lag screw. In this study, a mean anchorage of 46% and 31% for lag and positional, respectively, was seen. No impact of the percentage of anchorage of each screw was observed on the stability of the joint or the functional outcome, when the cumulative percentage of sacral purchase was over 38%. Greater strength against torsion, bending, and shear forces, despite an intrinsic greater stiffness for a larger screw than 2 screws of the same diameter, because the radius depended stiffness to the power of 4. The ventral orientation applied to the screws in this study leads to a complete purchase through the sacral body and across the ventral cortical bone. This results in anchorage through a cis and trans cortical bone of the sacral body. The pull-out strength of a bicortical screw is greater than a monocortical screw in a canine humeral ex vivo model in another study. Rates of loosening between 0% and 53% following surgery is reported in previous studies. Placement of a long lag fashion screw was more effective with fluoroscopic guidance in another study. The range of motion of the sacroiliac joint has not been evaluated in cats, but it has been measured in dogs using radiographs, median range of motion 7 degrees, or tomographic studies, range of motion 2 degrees for German Shepherds, 1.5 degrees for Greyhounds. Increased range of motion of the sacroiliac joint is seen with trauma, which could increase the stress on each screw. Even if the positional screw underwent failure, the pelvic canal diameter was maintained over 1.1 in this study. There's an increased risk of loosening of fixation in dogs with a These abbreviations are crazy. With a percentage of reduction less than 90% when a single lag is used. In this study, cats with a percentage of reduction 90% had a similar rate of excellent functional outcome, 78%, as those with a percent of reduction of over 90%. Comparable results have been observed in previous studies using lag screw, using single transsacral screw and nuts, tension band technique, and cannulated screws. So in conclusion, stabilization of sacroiliac luxations in cats is possible using 2 sacroiliac screws, one in lag, one in positional fashion, a low rate of complications. This technique seems to be comparable in terms of functional recovery with previously published reports of other methods using stabilization techniques in cats. So yeah, I mean, so the problem with this study, of course, and they mention it, is it's retrospective. So there's no standardization with the cases, and you're stuck with what you've got. And they did mention in this paper that this study was over 10 years of medical records they were looking at. So it's difficult to find cases that of cats with this type of trauma, and having owners that are willing to do it. But for veterinarians who perform these types of surgeries, you can now keep this in mind as a option. And then for pet owners, just recognize the difficulty in performing this surgery. You're dealing with very small landmarks, high precision, and there's little room for error. All right, guys, we'll see you again in the next video. Thanks.